Temporomandibular joint problems or jaw joint problems, shortened commonly to TMJ or TMD, is a very, very common problem in the population. Approximately 1/3 of the population will be affected by TMJ problems during their lifetime. However, despite the frequency of this occurring, there is very little strong evidence of how best we should manage it. And most of the studies, in fact, when I was tasked with this as a junior registrar to look through the literature and look at what's best, between 1965 and 2000, there were over 13,000 publications, very few of which actually showed anything in the way of randomized controlled studies or strong evidence. Even today, data collection for management of these disorders is limited to a few enthusiastic individuals. You will see reams on the internet of people how to manage this disorder, and at best, a lot of it is just trying to biopsy your wallet. The enthusiasm that we have for collecting data needs to be supported by our patients, and it's wonderful to hear the great outcomes that we're getting in the management of orofacial cancer and facial deformity surgery. We have similar sorts of outcomes, and unfortunately, one of the patients that I've treated, who's a consultant rheumatologist, is on a lecture tour in India at the moment and would have loved to come and talk to you about how the fact that her jaw joint replacements are by far the best joint replacement she's had, better than her hips, better than her knees, better than her ankles. So we do get very good outcomes with jaw joint replacement. But we need to show this to the public and, more importantly, to our financial controllers. And this is where NFORC comes in. So as you can see from this somewhat busy slide, not all patients, in fact the vast majority of patients with temporomandibular disorders, don't require surgical intervention. There are a number of phases in which to go through before you get to that stage. And unfortunately, we do have rather trigger-happy surgeons, dentists, etc., who will want to do more interventional treatments when it may not be in the best interest of the patient. And again, this is where we need to see randomized studies looking at outcomes. The UK is truly leading the world in looking at temporomandibular joint replacement particularly. We are the first country to publish national guidelines, which was the collaboration of all of my colleagues in 2008 when it was published. These were then taken up by NICE in 2009 and established as their preliminary guidelines as to what we should and shouldn't be doing. Despite this, we still have to ask for funding for each individual patient because the joint itself costs around about £6,000. However, when we presented the database that we established following this to the orthopedic surgeons and said, we would like to run this alongside your joint database, the answer was, well, it's far too complicated. All we want is a yes, no, or maybe. So the database that we have now, and has been established now for about 3 or 4 years, is far more intense than any other database in orthopedics or maxillofacial surgery, looking particularly at joint replacement. The outcomes that we're seeing up to 10 years are better than knee replacement, they're better than hip replacement, yet nobody hears about TMJ replacement. The average age of patients in the UK for TMJ replacements is 43. For hips, it's in the 70s, for knees, late 70s. So we're getting a long-term improvement in quality of life of patients in their working years. It has now been fully approved because of the NICE data looking at our database and saying, yes, we've got these data, we know that you're looking at it sensibly, and also because people publish their complications. And one of the papers that I've quoted here, or later, is about the complications that I've got from this surgery, not the great outcomes, as Ian is often alluding to. So in its simple terms, this is a bit of a combination between the former talks about facial deformity and joint replacement. This patient has a tumour of the head of his jaw joint, which is causing his face to be deformed, with the jaw having grown down too much here. Carried out removal of the tumour, an osteotomy, or broke the top jaw and levelled the way his teeth bite together. We had to wire his jaws together for a period of time so he would regain function of the joint. This is him post-operatively. It's levelled the degree of his jaw, and he can open his mouth and function normally. Slightly more gory slide. This is a joint replacement. It's the same as knees are made of. So this is titanium. This is high molecular polyethylene or plastic, and it fits individually to each patient against the base of the skull and functions. This is an X-ray of the whole jaws, and it functions to open and close the mouth so that these patients can chew again. And the vast majority of patients, their main problem is not just pain. The NICE guidelines, it's important to note, for orthopedic joint replacements, the majority of issue is pain and lack of function. It's the same with the jaw joint. So pain scores measured, 5 out of 10 pain. Imagine what that feels like. Mouth opening restricted, less than 2 fingers breadth. Unable to eat anything more than soft food, and naught is liquids only. Or their joints have collapsed so much that their front teeth don't meet, and we have to have a CT scan showing that the joint is diseased. The outcomes are truly amazing. Pain improvements of 90%. I would never promise a patient that we would completely eliminate pain, but particularly the rheumatoid patients we're looking at individually now are getting pretty much no pain at 1 year. Their diet improves to virtually a normal diet by 1 year. Their mouth opening significantly improves. Some of these are starting with relatively normal opening. Some of them are starting with mouth opening of 1 millimetre, and they are all gaining openings of 20 plus millimetres, on average 11 millimetres improvement. Yes, they have complications. Hip replacement, 0.5% infection rate. Jaw joint, because it's next to the teeth and mouth, which is a filthy environment, 2%. That's across the world. Temporary weakness of the face. My series, around about 1 in 5 patients get some temporary weakness of the face. Most of them resolve within 6 weeks, but about 1%, 1 in 100, get some permanent loss of movement of the forehead. It's a bit like overdoing the Botox. Dislocation of the joint. About 1 in 10 patients on the table will dislocate the joint, but if you temporarily stabilize them for a week, it doesn't happen. So it's a stable procedure. The problem is we don't know how long they will last. 20-year studies are there, but limited numbers. In the UK, there is 3 or 4 of us that have got good numbers at 10 years, and again, the outcomes are good and maintained to 10 years. We haven't yet seen the wear debris problems that you get with orthopedics. So just to summarise, the UK is truly leading the way in the management of TMJ disorders. However, we need to establish a more robust database. At the moment, the database we have is difficult to manage statistically, and for this reason we're moving with NFORC towards developing the database further and expanding it to look at new areas of research which will affect more people. TMJ replacement in the UK, 100 to 200 patients a year. TMJ disorder, which you treat with splints, 20 patients a week just in my clinic. So we need to look at what best treatment we can deal with, and that's one of the studies we've done with the support, or we are doing with the support of NFORC. We need randomized multi-center studies. This is what research is all about, and collaboration rather than facing off each other and saying, aren't I wonderful, is got to be the way ahead. Thank you.
Hello everybody, my name is Christine Yates, and it's an odd thing to say that it was my second pregnancy that actually brought me in contact with Ian Hutchison. During the course of my second pregnancy, I developed an overproduction of synovial fluid, which is normal in the course of pregnancy to help the pelvis to expand for delivery. In my case, the synovial fluid went to all my major joints, to my wrists, to my elbows, to my shoulders, and to my jaw. I can't describe the pain, and I can't describe what it's like to have a newborn baby and you can't open your hands, you can't change his nappies, you can't function properly. Anyway, this continued, and I was eventually referred to a local rheumatologist who had a fixation with how I looked, because she greeted me every time I went in by saying, "It's so hard to believe there's anything wrong with you when you've always got your makeup on and your hair done." And my response was, well, if I looked the way I feel, I would look awful. Why would I want to look as bad as I feel? Anyway, I was prescribed drugs, I was prescribed heat treatments, none of which worked, none of which touched the problem at all. I went on to discover an article in a magazine which described in complete detail what I was suffering from, and I presented it to this rheumatologist, who told me that, again, you look so lovely, but you shouldn't believe what you read in magazines or newspapers. I lost all faith in her and stopped going to see her. The condition continued until my third pregnancy, at which point all the aches and pains stopped. The hormones had balanced themselves, but my jaw by this time was pounding. We're up to 1984. Lots of complications. I would pass out, I would feel sick, I couldn't see straight, I couldn't open my mouth. My mouth opening at its worst point was 3 millimeters. And I can't describe what it's like to have food poisoning and be unable to vomit unless you vomit out of your nose. And that happened to me on one occasion, and that's quite scary. Eventually in 1986, my dentist said enough is enough, and she referred me to UCH. And I went through the usual process of tests, medication, suggestions, splints, bite guards. And at one stage I was told by a doctor that there is a procedure that exists to cure your problem, but I don't think it's right for you, so I'm going to put you on steroids. And that's the only time I've ever lost my temper with a doctor, by saying, you know, if my leg was broken and you knew that putting in a splint was the right thing to do, you wouldn't send me home with an aspirin. And I had to fight to be taken seriously, to understand that for all I look fine, I'm in agony. I can't sleep, I can't function, I can't think at times. Anyway, I had a very wonderful procedure at the Eastman Clinic whereby quills were inserted into what was left of my joint capsules. In fact, there was nothing left. And painful is one way to describe it. Transcendental pain, I think, is about the only way I could describe it. But that, in due course, brought me into outpatients one day, and I was taken into a room where Professor James was conducting outpatients, and also there were lots of doctors in white coats and students. And one of these doctors was a very young senior registrar called Ian Hutchison. And Professor James explained to me that what in fact was wrong, my temporomandibular joint, the cartilage that exists between your condyle bone here and my skull had disintegrated, which meant that my condyle bone was grinding into my skull, which was limiting my opening ability. And Ian took over at this point and said, this is what we can do, I can fix it. And he booked me in for 6 weeks later, and I had the first operation to repair the left side of my jaw. Thinking, that's it, I'm cured. But of course, unknown to me, because all the pain was focusing on the left-hand side, the right-hand side then kicked into gear and was in a worse state. So the following year, the right-hand side was repaired as well. I've subsequently had 2 repairs altogether on the right-hand side because it's played up, and at one stage, I remember you telling me it was actually in fragments, but we left it and it sort of fused itself back together. I also had to have both parotid glands removed from my face for another reason. So all in all, I have quite a tapestry on my face. I'm very lucky that my scars are very minimal. I have scars down my neck and scars in front of my ears. I look like I've had a very bad face job. And in fact, one day in Tesco's, I was being stared at before I'd had my stitches out so intently by a woman who just couldn't take her eyes off the bright blue stitches and must have been thinking, God knows what she paid for that, but it didn't work. And I said to her, in the end, I actually turned around to her and said, you think this is bad? You want to see the other fella? But without what was done for me, I don't know where I'd be, because my sanity, with 3 young children and a home and a full-time job, was, it's hard to quantify. By the time I'd finished my treatment, which I think was in 2001 altogether, which was at the start of saving faces, all I can say is what was done for me saved my mind. And what is being done for other people, if you hurt, if you're in pain and you know there's something wrong with you, I would hope that this will encourage any doctor not to say, well, your hair looks nice and you've got your makeup on, so there's nothing wrong with you. If need be, well, it shouldn't be the need, you shouldn't have to push it. I would hope that this encourages doctors to listen, and that you come to the people like Ian and all the other doctors here who can help you with whatever your problem is. And I would like to thank you still after all this time. Shall I go now?
What I would say about Christine, and you may not have picked up on it with all this Ian Hutchison rubbish going on, is actually she saw several different clinicians, some of whom who said, take some Brufen, some said take steroids, some said wear a splint, some said here's some acupuncture, some said here's massage, all different talks, and no test ever done to compare those treatments to see whether any of them work at all or whether one works better than the other. So a lot of money is spent on all these treatments. Is it valuable? We don't know. So we're not only just talking about playing with patients' lives by trying out drugs and treatments that we don't know necessarily work, but we're also costing the health service money.